Jessica, if you'd like to present on the mental health omnibus bill, that would be great. Thank you and welcome.
Thank you. And I'm going to try to share my, I don't know if I can do screen sharing. It says I can't share screen right now. And if I can't, that's okay.
You know what? I didn't make you a co-host yet.
It's okay.
Let me do it I'll do it anyway.
Okay. So Betty, as you're doing it, I'll just start talking.
Right.
So in August, Governor Charlie Baker, got it, thank you, signed this mental health omnibus law. And this has literally been years and years in the making, multiple legislative sessions. And it's a behavioral health bill of this size and covering this many different topics is pretty historic. So it's exciting. I think it goes a long way to advancing access and advancing quality. There's a lot more work that still remains to be done. And as Jen and I are involved in now, there's also a lot of the devils are in the details. So kind of working through implementation and how the law actually plays out in practice. But I think the takeaway is really credit to the governor and the legislature and advocates like yourselves for getting something of this size and this importance across the finish line. Okay. All right, can you all see my screen?
Mm-hmm.
Yes.
Okay. So I can't see all of you. So as Jen said, if please just shout out. Okay. So it's also called an act addressing barriers to care for mental health. That's the longer name of it. And the technical name you might also hear is called Chapter 177. So those are two of the names that you might hear for this massive mental health omnibus law. It just went into effect 90 days after the governor signed it on November 8th. Not everything gets started on November 8th. It's not like one big power switch where everything turns on that date. Some provisions have different start dates that are outlined in the statute. And some of them just take some ramp up time to get started. But effectively, all of it should be being developed or worked on now. And as Jen talked about, this didn't happen all by itself. So there's a lot of other things happening. Jen just talked about 988. She also talked a little bit about the roadmap for behavioral health reform, and this kind of complements and wraps around all of that. So I'm going to walk through quickly some of the provisions in the new law, and I kind of broke them into two categories. Okay, so the first category is service delivery and system reforms. I'm going to go through this pretty quickly, and we'll take some time for questions at the end. And then we also have a fact sheet about all of this that I'll put in the chat in case you want more information, and Jen and I are also always available. So one of the first things is that it creates something called an Office of Behavioral Health Promotion. So health promotion activities are already happening in the Commonwealth, meaning raising awareness about behavioral health, addressing stigma, helping people recognize signs and symptoms, helping people know where to go if they need help. But it's happening in all over state government. So it's happening in the Department of Public Health, it's happening in the Department of Mental Health, it happens in the Bureau of Substance Addiction Services. And what the law does is it creates one central office in the Executive Office of Health and Human Services that's supposed to coordinate all these different initiatives across different state agencies and help the approach be a lot less fragmented. Jen already talked about the 988 suicide and crisis lifeline section of the mental health omnibus law. And one of the biggest parts of that is the establishment, the creation of a commission. So there hasn't been a tremendous amount of input from the public or stakeholders in 988, and this commission will change that. And just so you all know, NAMI Mass is a member of the state 988 commission. So as you're hearing more about 988 in the community, if you use 988 yourself, if your friends or neighbors do, and if you have feedback, there will be a NAMI representative on the commission. It'll be really important to bring your voices and perspectives to those meetings. Jen also talked about 911, and there are 911 enhancements in this new law. Now, ideally, as Jen started out her presentation, saying a lot of times you try to avoid police interaction whenever possible. That behavioral health intervention tends to, is a lot more therapeutic. However, even with all these new helplines, people will still call 911. And there are times when 911, especially if there's imminent risk of harm to an individual or somebody else, is appropriate. So there are these 911 is usually local or it's regional with something called these public service access points. And the new law requires the regional public service access points. They require them to be able to respond to behavioral health emergencies. And they require them to be able to connect with and dispatch mobile crisis. Because right now, 911 is equipped for medical, physical emergencies, fire, and potentially criminal emergencies. Not all 911 centers are equipped for behavioral health, and that this will change that at the regional level. There's a lot of provisions in the new law to address emergency department boarding, which is in crisis state right now, and one of the greatest symptoms that our behavioral health system is broken. So the first two bullets is it requires the development of both a youth and an adult emergency department boarding portal. And the boarding portals will include real-time bed search functions. So right now, if somebody is boarding, it usually takes somebody from the hospital or family members to call around to multiple hospitals or multiple treatment centers to try to find somebody a placement. And there aren't many. And this, in a sense, centralizes all that information, and it makes it transparent so that hopefully transfers will be more efficient. And it also, as Jen pointed out in her presentation too, data is so important, right? So if we have a real-time bed search function and we continue to see that there's no crisis stabilization beds, for instance, that helps us policymakers and advocates know that we need to invest more in that part of the system and grow that part of the system to meet need. And another thing it does is it requires all emergency departments to have mental health professionals available at all hours. So at not all emergency departments in the Commonwealth, if you go for a behavioral health emergency, will there be a mental health clinician available? So this requires acute care hospitals to have their own, not outside mobile crisis, but their own mental health clinicians available to help patients that enter through the emergency room. There's provisions to strengthen behavioral health of students in schools. So kind of moving upstream, it creates a new statewide program to provide training and technical assistance to schools to implement behavioral health services and supports. And it also really tries for kids that are struggling to avoid suspensions and expulsions as much as possible, and to try alternative remedies and to document those alternative remedies before any suspensions or expulsions happen. And on the criminal legal side, there's also reforms, and Jen did a lot of work on this. There's something called a status called mental health watch, where prisoners go where they're at imminent risk of self-harm or suicide. And there's a Department of Justice report that came out that talked about how poorly people who are incarcerated are treated on mental health watch. And under this new law, people who are incarcerated can petition to get out of the prison and mental health watch and go to a behavioral health treatment facility to get the behavioral health care that they need, because we know that the prison setting itself is not therapeutic. All right, the second category is access, equity, quality, and accountability. There's not a lot of new coverage requirements for health plans in the new law. So these coverage requirements apply to Mass Health, Group Insurance Commission or GIC plans, and all commercial health plans in Massachusetts that are sold in Massachusetts and also regulated by the Division of Insurance. So what isn't included are the gigantic ERISA self-funded plans, but what is included are the small group and individual fully insured non-ERISA plans. Those are the ones that are regulated by the Division of Insurance. So now all of those types of plans are required to cover an annual mental wellness exam, just like we get our annual physical health exam, community-based acute treatment, CBAT, and inpatient psychiatric bed. They're also required to cover something called psychiatric collaborative care, which is in a primary care setting when behavioral health gets integrated into that primary care team. And emergency services programs, ESPs, which includes mobile crisis intervention and community crisis stabilization. And another thing that's exciting is that it requires all the plans that are regulated by the Division Insurance to maintain coverage for individuals 26 years old and older, allows them to stay on their parents' health insurance plan if they have a mental health or a physical disability, which is great. If you remember, the ACA requires coverage up until age 26, and this new law allows folks to stay on their plans after age 26 because of a physical health or mental health disability. There's also a lot in the law about parity, right? Making sure that your behavioral health coverage is treated the same as your physical health coverage. It also has a lot of consumer protections related to if you're submitted a complaint that you got denied care, that they respond in a timely manner, that they issue notices in a timely manner, that they let people know about appeal rights, that they promptly respond to grievances. And if they don't, the plans don't do it within certain time limits, it gets ruled in your favor, which is great. And it also requires the Office of Patient Protection to kind of monitor these complaints and these grievances and denials, and to look for trends. And if there's a plan that has a bad track record, they can get referred to the Division of Insurance or the Attorney General for investigation for a possible parity violation. There are also some great provisions in there about equity. It requires study of ways to improve access to a culturally competent mental health and substance use system. It also requires DMH, when they're doing contracting, to think about transportation, especially in more rural areas of the state, and to make sure that the services and networks are accessible. And then it also includes, to address the workforce crisis, it has provisions that support folks who are working toward licensure, who are newer in their career. It also expands the scope of practice for certain professionals like psychiatric, nurse, mental health, clinical specialists, to allow them to do more as a way to, we were talking about workforce before, really expand the number of people who can serve residents of Massachusetts so that they can get care in a more timely manner. And with that, I'm gonna stop sharing. And I'll also put the link in the chat with the longer issue brief. So the law itself is over, I think it's over 100 pages, Jen, and our fantastic colleague, Kate Alicante, summarized it in 8 pages. So you can read the 8-page version, yeah, instead of the 100-page version. And then if you have any questions after this too, I know I rushed through it. We're happy to help.
People were asking if we could share the slides as well. I said that, yes.
Yeah, absolutely. And Betty, I sent them to you and I can send them to others. How are the easiest ways to do that? Just let us know.
Betty, do you think that maybe if they send you the information, you can share it with the folks that registered?
I think that's a good idea. Just if you send me the information, I can share it with the folks that registered and then they can go over it again. And then I can also, I'll have it also with the recording too.
Okay, thank you. Thank you so much, Jessica. That was so informative. Okay. Does anybody have any questions for Jessica? Mhm.
Can you just tell us a little bit more about what the roadmap is? Is it deciding who's doing what, or what does it mean to have a roadmap?
Yeah, no, that's a great question. So, there's a lot of major things happening all at once. So Jen talked about 988. I talked about the mental health omnibus law. And then there's something else. It's called the behavioral health roadmap. And they all kind of work together. None of them are completely separate. They all are meant to be kind of synergistic. So the roadmap actually started before COVID, and Secretary Sutters and her team did, she wouldn't even call it a behavioral health system because she thought it was so broken. And fortunately for us, behavioral health is the issue that's nearest and dearest to her heart. So she did listening sessions, and these listening sessions went on for months with family members, with individuals, with providers, with payers, with advocates, all different stakeholders, to hear what wasn't working and any ideas that folks had for improving the behavioral health system. And things got a little bit slowed down with COVID, of course, but I believe in February 2021, they released the roadmap. And what the roadmap is it's a plan to completely reform the community or the outpatient behavioral health system. And it's meant to be for everybody. So the Secretary of Mass Health has, and DMH, Department of Mental Health, has the most control over the public system, right? And the public payers. But it's also meant to impact people who use the private system as well. And it's a multifaceted plan, and I can put a link to the PowerPoint in the chat. But basically, it's all the same goals. It's improving access, improving quality, and advancing equity. And there are lots of different parts of the roadmap. And one of them is this concept of that helpline that Jen was talking about, that 24/7, 365 number that you can call, where you talk to, that's the clinician, you talk to a trained clinician, and they'll help you navigate the behavioral health system. And not only will they help you get an appointment, but they'll follow up with you to make sure that it's stuck. And if not, they'll keep working with you. Like, that's kind of mind-boggling, actually, compared to what we have now. So this concept of the front door behavioral health helpline is part of the roadmap. And that it's also, as Jen was saying, what makes 988 so confusing in our state is because both of them are happening at the same time. The helpline from our secretary and 988 was really coming in from the national level, as a national requirement. And then another big part of it is the state has contracted with 25 different providers to become community-based behavioral health centers, community behavioral health centers. Sometimes you hear them called CBHCs. There's like 5,000 acronyms, community behavioral health centers. And to be a community behavioral health center, you have to be able to provide a wide, or is very prescriptive. You have to be able to provide a wide range of services. Everything from walk-in or same-day care, urgent care, which is something that we didn't even have before. Behavioral health urgent care, right? We have all these like physical minute clinics, but we didn't have behavioral health urgent care, and now we will with the roadmap. More culturally competent and linguistically competent care, and then enhanced crisis services. So we're all going to see, thank goodness, a lot of enhancements to the mobile crisis system, and also community crisis stabilization with these new community-based behavioral health centers. And they're geographically based. So the thinking is that no matter where you are in the Commonwealth, you should be near to one of these 25 CBHCs, community-based behavioral health centers, that provide this comprehensive array of services. And Catherine, I think you asked a really good question before about like workforce. So like we're in the middle of this workforce crisis and this is all happening, right? But the state is doing enhanced payments for the 25 organizations that have been selected as the community behavioral health centers, so that they can staff up and be more fully staffed to be able, all these things go live in January. It's only a couple of weeks away. It's kind of mind-boggling. And I know that on the provider side, like it's a lot. It's a really quick ramp-up period. And I think as advocates, I mean, we all have to, there's so much excitement and so much promise. And at the same time, we also have to, you know, it's our job to be watchdogs and monitor how this is all going. And there's some important questions, like if all the staff are going to the community-based behavioral health centers, what's happening to the other parts of the behavioral health system, right? And is this really operating like how we envisioned, or how the secretary and the stakeholders hope? And if not, we need to work with the new administration to let them know what's working and what's not, and how it can be improved. So the great news is that there's a lot of things happening, that the things that are happening are remarkable and historic. And it's only because we've had leadership who are deeply passionate about these issues, and advocates like all of you who have raised their voice. And part of the challenge will be, how can we make sure all these parts are working together and amplifying each other? And are they getting rolled out and happening in the way that it was envisioned? And if not, how can we problem solve and troubleshoot?
Jess, since our affiliate is on the South Shore,
Yeah,
is it safe to say that Aspire is one of the 25? That's the main one for our area.
I'm gonna look it up right now because that's a great
Yes.
question.
Yes, it is.
That's
Great. Thank you.
That'll be such great news for them, because they were losing so many people to low pay. And
Yes.
it's
Yeah.
hard work. So it's great to hear.
And I'm gonna plop in the chat the whole list of the 25.
Oh,
Okay.
great. Mhm.
Oh, that's awesome.
And Jessica, this is also for, it's not just for behavioral mental health, but it's also for substance use treatment
Yeah.
as well. Yeah.
Yes. Thanks, Kimberly. That's a great point. And that's part of the system has been so fragmented, right? With mental health over at Department of Mental Health, and substance use over in Department of Public Health. And yes, these CBHCs are, in order to be a CBHC, you have to have the capacity and the expertise to be able to care for people with co-occurring conditions. So great point, Kimberly. And I also know as part of their ramp up, all these, like the Aspires of the world, with these new services, you have to get licensed in all these different state agencies to be able to care for people with co-occurring conditions. So yes, that is happening. Thank goodness.
Yes.
Right.
Do you, I'm sort of thinking of this, I mean, it's a wonderful Christmas present. But, you know, in reality, when you think about, you know, all the people that need to be trained, all of the glitches that are going to happen because they always happen, right? And then the problem solving and all of that. Do you sort of have like an imaginary year where it all might really be up and running? Maybe not perfectly, but would you say like in 5 years, it might be like somebody could actually use these services? Or would you say 3 years, or do you have it sort of in your head, you know?
Well, if you ask the secretary, she would say January,
Right.
right? If you ask the secretary, she would say January. And nobody should wait. When they need services, you go, you call the helpline and you get the care. I will say that, you know, Jen was doing a great job talking about like the helpline and 988. We have heard that to reduce the fragmentation, that the helpline is going to apply with the national folks to also become a 988 call center, so that literally everything will be in that one number. And it takes about 6 to 12 months to be able to get that kind of certification from the national folks. So I'm hopeful in 6 to 12 months, the behavioral health helpline and 988 will be a lot more integrated than they are right now. And I really think, Jen, I'd love to hear what you think, but I think in terms of one of the biggest barriers is the workforce. And the state is scrambling and investing tons of money. Our American Rescue Plan Act's federal money into loan forgiveness and state budget money. There's all the revenue surpluses into loan forgiveness. And now they're starting to think about even kind of more aggressive workforce solutions like tuition assistance or signing bonuses or staying bonuses, or I think things are going to change dramatically in January, and I think the sooner we can get on top of the workforce issue, the better off the whole system will be. Jen, what do you think?
I was just going to answer a slightly different part of the question, just in terms of just 988. I think I agree with everything you said, but just about 988, I think looking at examples in other states, which might have been further along in some ways to having a call line that was like 988, that maybe not starting from a suicide prevention model, but starting from a sort of broader crisis lines specific crisis lines that they merged together, that it was a multi-year process. They've described it in some places as a multi-year process to getting to the point where they think that all those lines will be integrated, and then that they'd have the systems in place so that they could handle, I mean, their goal is to handle as many calls as possible without referral to emergency services or recognizing that some will always need to be referred, but to have a good operating system. Then in some states it's taken several years, and some states have view it as even taking more time. You know, they've taken several years and they want more time. I think the idea is that it's recognized as an evolving process, not something that's just going to be achieved overnight. Not to say, but I agree with Jeff that you should be able to, we should be able to expect that the roadmap helpline will be up and running in January, and that 988 should be giving proper information now when people call.
Are there any more questions? Just looking through my screen here.
I just have a comment.
Yeah. Go ahead, Sheila.
I mean, 20 years ago, I didn't even know there was a NAMI. In 2022, and now you're talking about the roadmap and 988 and crisis centers, and Oh my gosh, I think it's awesome. Okay, that's it.
Thank you. It really is quite a feat. No, just take
And-
time
and-
to probably interval it all. Yeah, go
I
ahead,
did a
Jen.
test this morning. Sorry, I did a test this morning. Asked my husband, I said, I have this thing tonight. Don't talk to me between 6:30 and 7:30. And of course, my brother in the middle. Sorry, my brother came. I think my brother came in and when I was talking, and like someone was in the house. I had no idea who it was, and he doesn't live here, so he like California. So like someone came and left, and that's why I was a little distracted. But I said to my husband, I'm doing this talk on 988. I was like, do you know what 988 is? He's like, yeah, it's the new mental health number. I was like, oh, I mean, I don't know if he knows much more than that, but I was like, oh, good, okay. Well, people seem to know that. He doesn't deal with that day to day.
Great.
I would also encourage both of you ladies, Jess, maybe you can do this, or Jen, either one of you, to talk about what your center actually does, and about your newsletter that you put out. I get the newsletter all the time, because that's really how I found out about all of this, and it's a great vehicle for advocacy.
Mhm.
Jen, I'll kick it off and we can tag team. So MAMH we're a little bit different than NAMI because we're not a membership organization. We're kind of like a neutral convener in the behavioral health space, but almost all of us are people lived experience and family members. So it's always driven toward the perspective of helping people get access to higher quality care. And so we work with organizations that represent family members, that represent people lived experience, that are the providers, both the community-based and the inpatient, payers, state government, philanthropy, federal government. And our whole mission is to advance mental health and wellness. And you're meeting Jen and I, and there's three of us that are kind of on the advocacy team, and we do legislative and budget and now regulatory advocacy now that we have this massive law to implement. And then the newsletter, when we have staff meeting, we'll pass along the kudos. I appreciate it, Betty. We have a knowledge dissemination team, and they do trainings and they do the newsletter, and they do webinars sometimes, and they do social media. They work with traditional media, basically to help raise awareness and educate folks about the issues. And then we also have something called Network of Care, which is something that we manage, and it's kind of in conjunction, or it's kind of like NAMI Compass. So ours is just a website. It's a service directory of all mental health and substance use services in the Commonwealth. And then NAMI Compass is if you want to talk to a live trained operator to navigate the healthcare system. So we do those three things, and we're like very fact-based, evidence-based. We do a lot of behavioral health system reform, which is what we've been talking about tonight, but we also do a lot of like intersectionality. So a lot of work with education, a lot of work, Jonathan was talking about housing, safe havens, a lot of work, Jen, especially with criminal legal reform. So there's 11 of us, and our president and CEO is Donna Mosh.
Thank you.
Thank you.
So if you do sign up for the newsletters, I think you'll also get the action alerts, which are come out occasionally asking, getting highlights of legislative priorities, often it's legislative priorities that we could use help advocating for. And it explains what's going on sort of at key moments in the legislative process.
Yeah, they were so easy to use. When I would get those, I mean, it was like a no-brainer. You read it, you agree with it, and sign it, and off it goes.
If it were always that easy, it would be a great job. I could just see that.
It's like always enclosing an addressed envelope with a stamp on it.
Great. And thank you for sharing that information on how people can subscribe to your newsletter. Thank you. You're right, Betty. It is easy just to sign on if you want to advocate for in support of their advocacy efforts.
Well, I'm
Alright.
so glad that both of you gave up at least the early part of your evening to join us and help explain just the beginning part of this whole process. It sounds to me like we should have a part 2, maybe in, next fall, and, and see what's happened, or in 6 months, and see what's happened between now and then. Sort of a follow-up, huh? That would be interesting to see. But thank you so much for joining us tonight. We really appreciate it.
Yes.
Thank you.
Thank you very much.
And keep us posted if you're learning stuff about the systems, or if there's frustrations, or hopefully we'll hear at the commission from the NAMI person too.
Oh, good.
Yes, right.
Thank you for that.
Good.
Thank you.
Okay, then we'll say goodnight if we don't have any more questions. Okay, thank you again, both of
Yeah,
you.
thank you so
to
much.
the rest of you for joining us this